Welcome to Rotterdam. Welcome to Resuscitation 2025. To all attendees, enjoy the Congress, the city, and the mission we share. Here we go. It starts with 3 simple steps to save a life. Check, go, compress, push with the beat, no time to rest. Check, go, compress, together we fight, we give our best. We are ERC. We are the rhythm that sets live free. We are here. This is our heart, our legacy. We are ERC.
Dear ladies and gentlemen, welcome the President of the European Resuscitation Council, Federico Semeraro.
We are ERC. We are the rhythm that sets live free. We are here. This is our heart.
So, hello to everybody. Welcome in Rotterdam. Oh my gosh, it's a true honor
The rhythm
to be here
that
with
sets
all
us
of you. 3,000. As the first Italian president of the European Resuscitation Council, at the very first presentation of the ERC Guideline 2025, at the very first ERC Congress ever held here in Netherlands, wow, what an emotion. My deepest gratitude goes to everyone who made this Congress possible and to all who believe that this dream could become reality. At effort, welcome also to the International Liaison Committee. We have a meeting, an amazing meeting. Welcome in Europe. Welcome to Rotterdam. We spent lovely days. We had an amazing days yesterday. And oh my gosh, our website received a lot of boom. So my deeply sincere thanks to the incredible ERC office team in Neil, now working from our brand new and truly fantastic headquarters. And a very special thanks to Jan, our CEO, our wise Gandalf the Grey, who has guided the ERC through the challenging post-COVID years with vision and calm wisdom. I would also to thank all the members of the ERC board for their constant support. Thanks to our General Assembly, the Governance Committee, Science and Education Committee, Young ERC, Diversity, Equality, Inclusion Committee, and 24 National Resuscitation Council. Wow. But thanks to the Young ERC, thanks. Our diversity is our strength. We are meeting in a time when the world has still not found peace after the pandemic, amid the ongoing wars and conflict in many places. It's such moment. It's a very not easy to feel pure joy, and even as we celebrate the release of the guidelines, I still vivid remember the day we launched the 2021 guideline. All of us sitting in front of our screen, doing our best to share hope in a dark and difficult time. That was under the strong leadership of my dear friend Koen Monsier, who I would like to thank especially for his steady, inspiring guidance through one of the toughest periods of ERC history and probably of the world. Today, despite everything happening around the house I feel a little optimistic, yes, because every new set of guidelines, every meeting like this, every handshake here in Rotterdam represent progress, collaboration, and life. So before giving you a glimpse of what awaits during this exciting Congress, it's my pleasure to invite the chair of National Resuscitation Council, Martin. Please, the stage is yours.
Thank you, Federico. I will keep it short, as I promised. On behalf of the Dutch Council, I would like to welcome you all. Special thanks to the ERC. Indeed, it's the first time ever that the ERC Congress is held in the Netherlands. I noticed that over 300 participants are Dutch. I was told that this is the largest number from one country ever. Now we are in Rotterdam, the town where I was born. Known from, among other things, the Euromast, Erasmus Bridge, lively town center, the ABN AMRO tennis tournament, and of course, Feyenoord, the best soccer team of Europe. Thank you. I see that you agree with me. Now I would like to pay attention to the tomorrow's rescue demonstration on the water. It will start at 5:50, so more than 1 hour before the social event will start. Today you will receive a flyer with all the details. It's for free, so everybody is welcome. I advise you to take your cell phone with you, otherwise you will regret it. But for now, I wish you all a pleasant stay. Thank you. The floor is yours.
So thank you very much, Martin, and thank you, Netherlands. So the ERC Congress 2025, the Guideline Congress, ready, steady, go. There is always an app for everything, you know. This is the Congress app. If you have time, download. So what awaits for your next days? 3 intensive days of science, discussion, debate, celebration, connection. Please take a look at the program, choose carefully, and make the most every session that inspire you. Now, talk about numbers. Wow. Over 2,000 from 79 different countries. Thank you so much for this. You should be proud. Top 3 country. Yes, Netherlands. Wow. And I think you should be proud about this. Couldn't start this. We have 13 countries for low-income countries, and we have, thank you so much for this, 105 participants. Among us are also survivors and co-survivors. Their voice and experiences have been part of the journey that shaped this guideline, and we are deeply grateful for their courage and contribution. Thank you so much. A big thank you, Giuseppe, Teresa, and the Supergirl Tatiana. Thank you for leading and shaping this incredible Congress, and to the entire Congress Committee, Scientific Committee, thank you so much. This is amazing. Thank you very much also to our sponsor and exhibitor. We are full of, please take your time. We have a lot of time during the break, during the coffee break and lunch. Please take your time to have a look around. Finally, I'm also happy to join you during the social event in Fudenhallen. So we expect, sorry for my Dutch, it's not very nice, I know. So we are waiting you for the social event. So let me spend only a couple of personal notes to my family and my Italian friend. Thank you for your patience, understanding, and support through these more than 20 years that I spent traveling far home, yet never far from your heart. So that photo was in Athens. Obviously, I anonymized with AI in anime mode because, yes, because it's okay. I wish you all truly inspiring Congress. May these days strengthen our science, our community, and our shared mission to save more life together. Let us forget the mission that unites us all to preserve human life by making high-quality resuscitation available to all. So, and now, it's a great honor to invite to the stage Katie Denti for the Peter Safar lecture. Thank you.
That will make it easier. Thank you so much, Federico, and thank you for the opportunity to join you here today from Canada. Oh, a few Canadians in the crowd. My goal today is to talk about the future of resuscitation science actually being outside of resuscitation. My disclosures are that I sit on a medical advisory board and I receive research funding from our funding agencies in Canada. I didn't have the pleasure of knowing Dr. Peter Safar, but I read quite a bit about him in preparing for this lecture. And one of the editorials that was written about him, I noticed this sentence that said, he had a relentless interest in everything and was a true humanist. And that really resonated with me. For those of you that don't know me, I'm a qualitative social scientist, and so I'm very interested in human experience and how humans construct knowledge. And when I looked up what a humanist was, it said it's someone who believes in non-religious ethical philosophy centered on human well-being, reason, and compassion, and that they seek to find meaning and morality in human experience, relying on science, reason, and empathy to solve problems. And so I immediately felt connected to Dr. Safar in that perhaps the way we saw the world was very similar. I am a true constructionist, and so as I said, I believe that knowledge is constructed by the people who live it, and that they and how they interact with society, and that there's that over the fact of finding an answer or a truth. And so between being humanist and constructionist, I think it's very important the way we look at the world actually changes how we ask questions and interrogate science. As I said, my research interests are in survivorship and co-survivorship, by-center CPR experience and training, and how we might look to the future of digital health to help support patient-centered care. And in all of these spaces, it is about how others experience an event or a situation that this drives my research. And I'll come back to why that's important in a minute. In most cases, I feel a bit like Where's Waldo? And I was very interested when I looked up Where's Waldo. This is the Dutch version. Waar is Wally? And then some of you who are from France, I believe it's Where is Charlie? I'm not exactly sure why Wally doesn't translate. But whenever I go to a resuscitation conference, this is a picture from Wolf Creek conference a few years ago in the United States, I tend to be the only resuscitation scientist who is a social scientist. So it's a bit like, Where's Waldo in the room? But I find that very invigorating. I find it invigorating to see the world differently than others in the room and to challenge sometimes what's being discussed by looking at it from a different perspective. As I said, how we see the world impacts everything we do, how we define problems and research questions, how we choose outcome measures, how we translate knowledge, and how we think we can change the world. I'm very inspired by the story of IKEA, how some of you might know that actually how they came to be the company with the flat packages was inspired by a very simple solution to moving a table to a photo shoot, that they needed to take the legs off of it. And from there, they decided that the flat packaging would inspire their entire business model, an entire way that they saw furniture and the customer experience. Something so simple, but it was actually driven by making things easier for the customer. And so how we conceive of problems and solutions, I think, is the future of resuscitation. We currently tend to see research questions in healthcare through a biomedical lens, with disease at the center, and where we think about diagnosis and etiology and interventions. But in fact, I think, certainly in my world, it includes more of a biopsychosocial model where we think about those individual factors, social factors, psychological factors, and emotional factors that really make an illness an experience. So as I said, I'm a social scientist, and the most important part of our definition is that we worry about human beings. And what's encouraging for me to be in the resuscitation space is that there's a human in every ring of the chain of survival. It involves a human being, whether that be the patient, the paramedic, the bystander, the physician, the nurse, and then, of course, at the end, the survivors and co-survivors. And this looks like a very simple, easy way to communicate what resuscitation is all about, what it takes to increase survival. But in fact, it's actually very complex. And complexity science, another way of looking at the world, would tell us that the complex adaptive system science would tell us that it's a combination of many knowns and unknowns, which I think really explains the situation of out-of-hospital cardiac arrest for sure, many knowns and unknowns. And that we have to think about things like the physical, social, and individual environments in the intersection of these as we go forward. But I'm still a little bit disappointed that resuscitation tends to be organized like this, in individual boxes. And we present the science in individual chapters. And so maybe this is somewhere where we need to think about the intersection within and between these chapters as we go forward. I was encouraged to see a new chain of survival posited by Dr. Schnaubelt, Greif, and Monsieur, and now calling it the chainmail of survival. And in fact, a nod to that complexity that's underneath all of the links in the chains. But in fact, I would say that still forces us to look at resuscitation through a very narrow lens and forces us into these silos of science. In other areas, we see that there's a lot of intersection, interdisciplinary science. This is a network meta-analysis picture of journal cross-citations across many different sciences. And we see that many sciences, even the physical sciences and the clinical sciences, have begun to cross-cite each other, which means that we are getting outside of our boxes. In the agricultural sciences, they actually developed a new science called agroecology because they recognize that they really are an overlap of several different kinds of sciences. And so, in fact, we don't have to reinvent the wheel to answer some of our most complex problems. Perhaps we just need to attach it to a new wagon. And I would say that from what I've read, Dr. Safar was actually an innovator in this space. So while he was an anesthetist and working in clinical medicine around mouth to mouth, he ultimately found a colleague down the block in engineering who had just developed the defibrillator. And then together, they came together, brought their brains and their sciences together to develop what we know as modern CPR. He also ultimately reached out to Asmund Lerdahl, a toy maker, to think about how we might develop a mannequin. So a doctor and a toy maker, what would they have in common? And here we are today with one of the biggest tools we have in education around CPR. So in fact, as a humanist, he was also an interdisciplinary scientist and perhaps started us on the path where we need to go. So if we come back to the chain of survival and just look quickly where we might be able to see this take shape, If we start with early recognition and response, I'll give a nod to my Canadian colleague, Dr. Brian Grunow, who is doing work, among others, around smartwatch identification of cardiac arrest, early identification. The trouble with this is that it's very difficult to detect a cardiac arrest when there's no flow or no pulse. A watch needs a pulse or flow to be able to detect something. And so he thought outside the box and partnered in Canada. We have medical assisted dying is legal. And he partnered with scientists in that space to be able to work with those patients to use that as a new model of cardiac arrest. Another nod to my Canadian colleagues, Tim Chan and Chris Sun, who normally work in the engineering, optimization, mathematical modeling space. And when they were able to partner with us in our resuscitation lab, we were able to look at optimizing AED placement and ambulance routes using math. Who would have thought that math could help us to say where to put an AED and where the ambulance should drive in a very congested traffic area? FYI, it should be by bank machines and coffee houses. In bystander CPR, which is where I spend a lot of my time trying to think differently about this, I often ask myself if we're asking the wrong question. We're asking, why don't lay people respond to out-of-hospital cardiac arrest? But in fact, that's not the question we should be asking. What we need to understand is the concept of bystanderism. What does it mean for another person who may or may not know someone to get down and respond? How do they feel? Do they feel that they can do that? And what are the societal norms that might be preventing them from doing that in different cultures and spaces? But psychologists have been thinking about this for years. Psychologists have been studying pro-social behavior, willingness, altruism, and empathy in great depth. So why we don't have more psychologists at the table to help us think about these questions? An example is the theory of planned behavior. This has been around since the 80s. And it talks about attitudes, subjective norms, and perceived behavioral control, and how that informs your intention and your behavior. Sounds familiar? We actually took that theory and we adapted it to bystander CPR in our lay responder experience paper a couple of years ago, and looked at how lay responder characteristics and beliefs also inhibit attitudes, norms, and self-efficacy that inform the intention to perform CPR. As well, in CPR, we have to think about skills and environmental constraints. But I would argue that most of our approaches to date have looked at this theory, and that we need to do more to bring in education theory, psychology theory, and sociology theory to really solve this problem. A great colleague, Barbara Farquharson, did a lovely systematic review of the psychological and behavioral factors associated with layperson CPR and found that only 6 studies looked at a behavioral theory of any kind. So we're leaving important information and knowledge on the table. When we think about advanced and post-resuscitation care, in hospital care, clinical care, we think about what happens to the brain during cardiac arrest. It is a heart injury and a brain injury. And when I presented this slide before, I often say you should be very nervous when a social scientist puts a slide up that has the word hippocampus on it. But in talking with my friend Bob Newmar, I learned that we shouldn't be so surprised when survivors tell us this. Because in fact, the parts of the brain that are injured during cardiac arrest lead directly to these symptoms and these outcomes. And so why haven't we been making the crosstalk between the basic brain science and the more psychosocial survivorship outcomes? In a beautiful paper by Gavin Perkins and Bob and team, they outlined exactly what we need to do to improve outcomes after post-arrest brain injury. But I would say it stops short of that next stage, which is how do we plan for that part of the care pathway? And how do we bring people to the table from rehabilitation, traumatic injury, psychology, sociology, to be able to help us to actually fill in that recovery and repair box more fully? I was very inspired by a talk that I was part of a panel I was part of with Dr. Amy Wagner from the University of Pittsburgh, who's actually a basic science and a physical medicine and rehabilitation doctor. And she's coined the term rehabilomics, and she's actually looking at how we can use genomics and personal phenotypes to be able to actually direct precision medicine around this and reduce the brain injury after cardiac arrest. I won't pretend to understand everything that she does, but this idea that we could actually adapt the ICF framework around impairment activity and participation and quality of life to include genomics and environmental states and personal traits is incredible. And she's actually personally cared for patients where they've reversed brain injury symptoms by using different types of medications that look at different parts of the brain. So it's very inspiring. And finally, how do we define good survival and quality of life? I'm so thrilled and excited that the fourth chain in the ERC chain of survival is now survival and recovery. This is an equally important part of cardiac arrest. But I spend a lot of time thinking about how we define good survival and quality of life. And I can unequivocally tell you it's not like this. None of you would be okay with being a CPC 2. Okay? And you know how I know that? Because I talk to people outside my science. I talk to survivors and co-survivors who are beginning to tell us survival is fantastic, but it's not good enough. These are the things that we worry about. We worry about ongoing anxiety and depression. We worry about returning to work, ongoing fatigue, change of family dynamics, personality changes. How can I leave the house when I'm triggered? I don't want to just survive. I want to thrive, and I need help to do that. Interestingly, not only are we learning from them, learning more than I ever have in any of my academic training from survivors and co-survivors, but other people have also been thinking about this for a very long time. We can learn from cancer, TBI, and stroke. They have put together beautiful models of survivorship and support for their patients. And we need to turn and learn from them and not reinvent the wheel, but hook our wheel to their wagon. I've been very honored to work with a very interdisciplinary group, and this has been my favorite project of my whole career because it's involved psychologists and psychometrists and survivors and co-survivors to help develop, and digital health experts to help develop an app to support survivors after cardiac arrest. We're just in development now and hoping to launch next year. I encourage you to go to the website. But this actually is entirely informed by what survivors want and when they want it. It's outside of the medical system. And so if we go back to the example of agriculture and all of the things that they recognize were part of agriculture and think about developing a new science, I wonder what perhaps our new science will look like. What will our interdisciplinary science look like? I'm encouraged by the new journal that Cone is part of, and looking at the combination of artificial intelligence and emergency medicine. This is the kind of crosstalk that we need to have, and the kind of crosstalk we need to have in our science conversations and in our guideline conversations for the future. So I posit to Federico and the ERC that perhaps next, the 2030 ERC Interdisciplinary Congress on Resuscitation, which is a room full of people like me, social scientists, psychologists, sociologists, anthropologists who can help us to really dig down and think differently about our science. And I would encourage all of you, the next time you write a grant or a paper or develop a proposal, that you think about inviting new people to your table, people you haven't worked with before. It will be hard. You will speak different languages. You won't really know each other's historical literature, but it will be well worth the partnership. So I leave you there with the future of resuscitation science being outside resuscitation. Thank you very much.
Federico, The Force is strong with you.
But I want to introduce you the real Master Jedi, Obi-Wan Kenobi, Director of Guidelines and ILCOR. And I love the real one, the giant of ILCOR, a couple of days ago. So, ladies and gentlemen, our Obi-Wan Kenobi, Mick Jagger, I don't know, Tino Greif on the stage. Thank you, Tino.
I'm Tino Greif. I'm in the ERC, the Director of Guidelines and ILCOR. So my job over the last 3 years, 2.5 years, and very intense last 6 months was working on the guidelines. And very short, you will have a lot over these 2.5 days about the guidelines. So I would like to thank some people. First of all, and you saw this already, there was a steering committee. So we started about more than 2 years ago. This is the steering committee, 14 people from all the guidelines, writing groups, diversity, office, project management, younger people involving diversity. But this was not all. So we oversaw the process. But around these guidelines were a lot of people who were leading the process over these years. So these are the leaders. For every guidelines we had 2. They were doing the hard job. But around these people, which produced 11 guidelines, 1 summary in collaboration with the European Intensive Care Medicine Society, the Society of Emergency Medicine, Anesthesia, the cardiologist, and the International Federation of Red Cross. And these guidelines were approved by, at this time, 31 national resuscitation councils. Now there came some more. All in all, 211 changes to the last guidelines and over 1,200 recommendations. This was only possible because all these people, these are now the authors of the guidelines, made a tremendous job in endless virtual meetings, discussions, emails. I was sometimes involved, and this was very interesting to listen to different groups and what they looked for. Office helped a lot. If you send me an email, I send you the slides. This is not a secret, and the quality is quite better. So, all in all, 141 persons, there's a typo, physicians, nurses, paramedics, teachers, ethicists, physiotherapy teachers were in from 29 countries, more than 40% women, nearly doubles as compared to the last time. We had public involvement. Each of the guidelines had a layperson to bring in the view of the community. The scope was out for public consultation, and in summer this year we had an open review process for everybody could give their comments. We got 820 comments on the guidelines. Something new also in the guidelines, diversity, equity, inclusiveness is a key part of our guidelines, specifically at this time in this world. I ask all the guidelines leaders, please add a paragraph, certain sentences, how to implement and how to do their recommendations in low resource settings. We made a faculty development program. 20% of the authors were middle or young or early or mid-career people, because these people have to learn how to produce guidelines, because in 5 or 10 years they are doing this. And at the end, when we were discussing, I said to my project management office, we need to bring this across, we need to implement this, and we need to produce a publication for the people out of this room, for every citizen, for every community, for the hospital administrator, for the politicians. So we produced a late-term version of the guidelines. And here's now the rest of the people who produced this, and I would like to ask you for a big, big applause for the work of all these people. Thank you. To finish this up, I would like to thank three persons very personally, and I call them to the stage. First of all, Jerry Nolan. Sorry, this is not the Jerry, this is the US-American punk rocker, Jerry Nolan. This is the guy we know. And Mali and Abel. Yeah. Over the last weeks, I don't know how, thousands of mails, hours, phone calls, forward and back, and really, this is Jerry here. Thanks a lot.
Yeah, it's been a real pleasure.
Amali.
Thank you so much, Tino. Thank you.
And Abel. These are the people. Come over here. A pleasure. A pleasure. And that's the end of my introduction. Now I have to make the transition to the next part. And this will be a short preview of the different guidelines in a very special format, which I like a lot. So I would call Sarah Taisiri Ben-Harif, where is she? Here, to the stage. And let's get started the show.
Thank you, Tino. My name is Sarah Taisir Ben-Sharif, and I'm a physician practicing in emergency departments in Brussels and in Northern Canada, as well as a freelance health journalist. It's truly a pleasure to be your moderator today and to have so many of you in the room with us for this important event, where we will review the key updates from the latest evidence-based guidelines on resuscitation. These presentations will give you the top lines of the updates, and over the course of the conference, we'll have lots more time to get into the details. So for now, let's stick to the key messages. During this session, we're going to have the pleasure of hearing from an expert for each guideline, and we'll be inviting them to the stage in groups of 4. Now, we're really excited to share these updates with you, and if you're just as excited about them as we are, we do invite you to share about them on social media using the hashtag Resus25. All right, with that said, please join me in welcoming our first group of experts on stage. To review the updates to the BLS, ALS, post-resuscitation care and special circumstances guidelines, we're joined by Mike Smythe, Jasmeet Soar, Jerry Nolan, and Karsten Lott. Thank you all for being with us. All right, it's great to have you all on stage with us. So let's start with you, Mike. So when it comes to the BLS guidelines, what is the key update and key message you want to share with us today?
So thanks very much, Sarah. It's my pleasure to be here today talking about the new BLS guideline. I'd just like to acknowledge that this guideline was produced by a writing group, and I'm just up here on their behalf. So the BLS guidelines haven't changed hugely, but there have been a number of important changes. Most significantly, we've changed the way we recognize cardiac arrest and alert the emergency medical services. So historically, we would say, is the patient unconscious or unresponsive, and are they not breathing appropriately? And if they weren't, then they were classed as being in cardiac arrest, and we would then initiate the call for EMS. We've changed that now. So if the patient is unresponsive, initiate that call to EMS, then whilst you're waiting for that call to be connected, proceed to assess for breathing. Now, the reason for that is because we've identified that most patients who are in cardiac arrest, that cardiac arrest recognition occurs during that phone call with EMS. So what we're doing is moving that recognition ever so slightly forward so we can have that time to first compression reduced. And it's a small incremental change, but incremental changes is what lead to better outcomes as we move down the line. We have made a number of other smaller changes, so we provide more detail on the role of dispatchers, and that's important because of what we're doing in the initial changes. We've provided better images for where to place the defib pads. We know that the apical pad, which is the pad that sits sort of toward the armpit, is often placed too low or it's too medial around the chest. So we've provided better diagrams to assist with where that pad should go. The other thing that we've done is we've provided additional detail about how to manage applying the pads when there is a bra in place. So we know from studies that women have poorer outcomes from cardiac arrest, and one of those reasons may be because they have a delayed time to defibrillation. One of the factors that we also know is that when we have simulations and a bra is present, that causes delays in terms of getting the pads on because people don't know what to do. So there are opportunities to essentially place the pads while the bra is in place, but if the bra is interfering with contact with the skin and the appropriate placement, then the bra should either be displaced or it should be removed or cut away. We've also provided additional information on how to perform CPR in patients who are obese. There is mixed evidence in terms of whether patients who are obese have better or worse outcomes, and there are questions about can we modify the way we perform CPR. And the evidence that we have on the whole is that we can't identify a means that is better or worse, so therefore we stay with what we've got. And finally, quite important from our perspective, is the BLS guidelines have now got two new figures that are quite important. So the first of those is the 3 steps to save a life, which is consistent with what's in pediatrics. And that's an important sort of message in terms of public information. And then for the first time ever, we now have a unified basic life support algorithm, which is fantastic. So that covers pediatrics, adults, in hospital and out of hospital cardiac arrest. So that unifies things and it makes it easier to teach. So those are probably the key changes that we've made.
Well, thank you very much for sharing that with us. And my follow-up question ties into Katie's presentation. So how do you think this unified BLS algorithm will change bystander comfort and confidence in providing bystander BLS?
So I think probably the key thing is it actually makes messaging simpler. So we have a unified message that's going out, and one of the common questions that we hear particularly from people who've learned adult CPR is, how do I do CPR in a child? Am I going to cause them harm? Actually, this simple unified algorithm makes it more apparent that it's actually acceptable to perform CPR by whatever means you know with a child. So hopefully we'll see a gradual improvement of outcomes as a result of this change.
Yeah, well, thank you very much for sharing that with us, Mike. Next, let's turn our attention to the ALS guidelines, and for that we have with us Jasmeet. So, Jazz, what's new or essential to highlight in the ALS guideline update?
Okay. Hi, Sarah. Hi, everyone. Great to be here. I'm going to reassure the audience that there are no major changes in the ALS guidelines. So all the great stuff you're doing at the moment, carry on. But there are some new emphasis and clarifications. So firstly, advanced life support continues on from basic life support, and we're hoping people get early CPR, early defibrillation as part of basic life support. So the people getting advanced life support tend to be those who are more difficult to resuscitate. So it's a continuum, and importantly, we want, one of the emphases is high quality chest compressions and ventilation. And the reason for that is that a lot of basic life support now is compression only. So by the time the advanced life support providers get there, the patient may have had very little ventilation. And there's quite a lot of studies now that show that even ALS providers don't give good ventilation. So high quality chest compressions, high quality ventilation. The next thing is, and again, the emphasis is on doing things effectively and well, and it's mentioned in the BLS guidelines, but it's very emphasized now in the ALS guidelines. that you have to get the shocks in early, but you do have to put the pads in the correct place. You know, the right pad below the clavicle, but the apical pad just below the armpit. So far more lateral than most people actually place it. So early ALS, effective high-quality chest compressions, ventilation, putting the pads on in the correct place, early defibrillation. And then we do move on to things like adrenaline, early adrenaline for non-shockable rhythms, delayed adrenaline for non-shockable rhythms. And then finally, as soon as you get to that cardiac arrest and you've started your high-quality CPR, you're giving your shocks, you've got to be identifying and treating reversible causes. And the earlier you can do that, the more survivors you're going to have. So, you know, normally ALS is a team-based activity. So your team members are going to be acting in parallel, working effectively as a team. So I'm going to stop there because I think those are the key messages. Early, effective ALS saves lives.
Thank you very much, Jazz, for those updates. We really appreciate it. Now that we've resuscitated the person, let's move on to the post-resuscitation care. And for that, we have with us Jerry. So, Jerry, what are the key updates in post-resuscitation care?
Thanks very much indeed, Sarah. I will start by saying that once again, this is a collaboration between the European Resuscitation Council and the European Society of Intensive Care Medicine. I think that's very important for implementation. I'm going to cover 5 domains. The first 2 relate to diagnosis of the cardiac arrest. And again, for the question of coronary reperfusion, again, if there's ST elevation on the ECG after resuscitation from cardiac arrest, then clearly urgent PCI or coronary angiography and PCI is required. For those patients that don't have ST elevation on their ECG, and if there isn't a clinical context suggesting a cardiac cause, then we're suggesting delayed coronary angiography and PCI. And there's probably a little bit more emphasis on delaying that group than there was in the previous guidelines. The second part around diagnosis, for those patients that don't probably have a cardiac cause, what we're suggesting there is that we should be considering whole body CT. And this is on the basis of a series of observational data suggesting that not only can you then get a diagnosis by using those CT, but it may well be that you can pick up complications of CPR, which is also very important for some interventions. The third domain that I want to touch on, and this is a very important and very large component of the post-resuscitation care guideline, is around prognostication. And again, this time we are strongly recommending multimodal approaches to prognostication, which includes clinical examination, use of biomarkers, imaging, and electrophysiology. But what we've introduced this time, and this is a new development, is the idea that as well as prognosticating a poor outcome, which is what we've focused on in the past, we can now look at some indicators of a good outcome. And by including that in the new algorithm, we can improve sensitivity for those investigations. Fourth domain, and I know Kainti Dati in particular will be pleased about this, is that we have a very much strengthened section on rehabilitation and follow-up, particularly with discussions around co-survivors as well, and that's a new development. And the final point that I was going to make was around investigation of unexplained sudden cardiac arrest. This is an area which is incredibly important, not just for patients, but for families, of course. And we, although don't necessarily have the same expertise as something like the European Society of Cardiology, it's important that we highlight this in our guidelines and point people in the direction of those guidance.
Well, thank you very much for sharing that with us. I'm quite intrigued by this recommendation to do a whole body CT, including CT pulmonary angiography, to identify and manage non-coronary causes of cardiac arrest. But I'm curious to hear, how do you expect this recommendation to be received?
So I think it's going to be controversial. I think it's going to be received perhaps differently in different centers and different countries around the world. And I can imagine in some centres there will be initially perhaps some pushback from radiologists. And I think it's important that we have dialogue, we open dialogue with radiology colleagues. And I can see this going in the same way as perhaps whole body trauma scans, which many years ago were also considered to be, I guess, controversial. And I suspect in a few years this will become pretty much a standard of care.
Well, thank you very much, Jerry. And now I'd like to turn over to Karsten to give us the key updates in the guideline on special circumstances. So, Karsten, what's new and noteworthy in this guideline?
Hi, Sarah. Thanks for having me here. So I'm kind of going to close the loop. Yeah. So we had a lot of work on thanks to all the hard work of the writing group members to bring things together. Question is, why do we need that special circumstances at all? Yeah? So we have excellent algorithms coming from BLS, moving on to advanced life support and then the post-resus period. Yeah? And these are all things we are describing in our special circumstances chapter as well. Yeah? We are focusing on cardiac arrest and we are focusing on the peri-arrest period as well. Yeah? We are fully aligned, and this is what you can see in the bottom of our key messages. That is most important to have uninterrupted chest compressions, to have some kind of blood flow, and to provide as much oxygen as possible to the patients, to get the best possible outcome of our patients. Special circumstances, on the other hand, describe a number of conditions where you need to deviate from that algorithm. And this is what we kind of covered in our chapter. Compared to what we did in 21, we have two totally new subchapters. We're looking at some kind of deformities. We have the request to look into that, and this is the patient with pectus excavatum. Yeah. So this is not that easy to start a standard CPR in that patient group, and we give some recommendations how to best perform chest compressions, ventilations, and where to best place your defibrillation pads in that patient to be able to treat them in the best possible way. On the other hand, and this is something where we have a lot of information on come throughout the last years, are the patients with a left ventricular assisted device. And this is why we needed to cover the topic as well, because you need to have an idea how to handle that patient outside the standard advanced life support setting. So this kind of goes hand in hand with what we already recommended in our trauma algorithm in earlier years, where we need at some stage not to initiate chest compressions right away if we have a limited resources settings, but rather start looking at the devices, checking the devices, and try to make them work before you jump into the standard BLS and ALS program. That gets us into trauma. We had to focus on the trauma algorithms again. What we did in the 25 edition, we added a number of clarifications, because the 21 trauma algorithm caused a lot of discussions. What to do first, what to do best, and how to prioritize your measures. We added a lot of clarifications on that and de-emphasized on some of the invasive procedures, because we have recent data that indicate that these might eventually cause harm. So especially for the catheter interventions in trauma patients like Reboa is only recommended from the ESC in study designs in the future. And last but not least, we had a close look and had a very effective working group on the pregnancy topic. So there's a number of recommendations coming out of the pregnancy topic, covering the pre-arrest period. So we added a number of P's to the 4H's and the 4T's. We're going to tell you about that in the upcoming sessions on special circumstances. You will learn about the newly implemented 4 P's in pregnancy and the peri-arrest period on that stage.
Thank you very much, Karsten, for sharing those sneak peeks with us. And indeed, you'll get lots more details in the next sessions over the course of the conference. So that marks the end of our first round of speakers. Please join me in warmly thanking them for their expertise. Thank you. Thank you. Thank you. Thank you. It is now time for our next 4 speakers, who will cover the updates for the guidelines on epidemiology, systems saving lives, ethics, and education. Please join me in welcoming to the stage Enrico Baldi, Sebastian Schnaubelt, Johannes Wittig, and Sabine Nabeker. Welcome to each of you. So I'd like to start with you, Enrico. So can you tell us what is new in the epidemiology guideline? What would you like to highlight?
Yeah, in our chapter, we decided to cover 5 main themes: out-of-hospital cardiac arrest, in-hospital cardiac arrest, post-resuscitation care, autopsy and genetics, and remote low-resource settings. Regarding out-of-hospital cardiac arrest, the EMS treated incidence of out-of-hospital cardiac arrest is about 55 per 100,000 inhabitants. The survival is very low, 7.5%. However, only 9 European countries have an out-of-hospital cardiac arrest registry with full population coverage, but a registry is crucial to understand what is needed in a given setting. And so we suggest and we recommend that all the European countries should establish a national out-of-hospital cardiac arrest registry, adhering obviously to the Ustein guidelines, because it is the only way to inform healthcare settings and to inform cardiac arrest response to improve survival. Regarding in-hospital cardiac arrest, the incidence in Europe is 1.5 to 2.8 per 1,000 hospital admission, but the evidence are really scarce in this context. And moreover, concerning the alerting of internal emergency system, the proposed internal telephone number, the 2222, is implemented only in 2% of the European countries. So we recommend to expand the research on this topic, to create in-hospital cardiac arrest registry, and to use and standardize the way to call the internal emergency teams with the 2222 telephone number in European hospital. Post-resuscitation care, we highlighted that the rate of poor neurological outcome depending on if the withdrawal of life-sustaining therapies is practiced or not in the different countries. And we also pointed out that physical and non-physical limitations are present in many, many patients after an out-of-hospital cardiac arrest. Also, we have seen in the Peter Safar lecture. And so we also seen that the majority of out-of-hospital cardiac arrest survivors expect to access to a multidisciplinary team after the out-of-hospital cardiac arrest. However, only 1 out of 3 receive cardiac rehabilitation and only 1 out of 10 receive brain injury rehabilitation. And so we therefore suggest to evaluate physical and non-physical outcome in all the patients after an out-of-hospital cardiac arrest, and to allow the possibility to access to post-resuscitation rehabilitation services to all the patients after an out-of-hospital cardiac arrest. Concerning autopsy and genetics, despite autopsies are really crucial for identifying a genetic cardiac disease in young victims and with the possibility also to protect their families, the execution of an autopsy under the age of 50 for victims under the age of 60 is not routinely performed in many European countries. And moreover, a clinical actionable pathogenic or likely pathogenic variant is present in up to 25% of the sudden cardiac arrest victim under the age of 50. So also post-mortem genetic analysis are really important on this topic. And so we recommend for the first time in ERC guidelines that all victims of unexpected sudden death under the age of 50 receive a full autopsy, including genetic analysis. And also we suggest that the results of autopsy and genetic results will be managed by multidisciplinary teams in specialized clinics to also offer counseling to the families and eventual screening to prevent other sudden death in the same family. And the last topic is about low resource setting. We highlight that bystander CPR rate and the IDUs in lower resource countries is lower than in higher resource countries. And also lower resource countries don't have out-of-hospital cardiac arrest registry adhering to the Ustein and based on a reference territory. So we suggest to create and to develop epidemiological registry also in low resource setting countries. And regarding remote areas, the early BLS and the rapid response by EMS are really important also in this area to improve outcome. And so we suggest to improve the emergency response because in this way we can save more life also in this context. And please let me thank to all the writing group members of the chapter of epidemiology. It was an outstanding journey.
Well, thank you very much for sharing those highlights with us. I do want to follow up on this recommendation to do a full autopsy, including genetic testing in young sudden cardiac arrest victims, which, as you said, is not routinely done in many European countries. I'm wondering, why do you think it's not already routinely done?
Two reasons for me. The first one is culture, especially in the southern part of Europe. I'm from Italy, and so I know the culture is the first problem. The second one is the lack of knowledge. I give you a practice example. On Monday, one 19-year-old boy was saved during a basket competition in my city, in Pavia. And we know the day after that his father died for sudden cardiac arrest. His grandfather died for sudden cardiac arrest. And probably he have a genetic cardiac cause of the cardiac arrest. In 2025, we cannot arrive at the third generation of person died for sudden cardiac arrest in the same family for the same genetic disease.
That's a very compelling reason indeed. Well, thank you very much, Enrico, for sharing that with us. Up next, we have Sebastian for the guidelines on systems saving lives. So what are the key updates here?
Yeah, well, the system's providing guidance for all the other chapters as well, because they're about the underlying system, making everything possible the other chapters tell us about. The systems chapter that we've had in the previous guidelines, of course, all the basic ideas, they're still there. There's no major changes in that. But I want to highlight a few points that need special attention, in my opinion. As you've seen when you came into the Congress venue, we've reintroduced the chain of survival. In the last update of the guidelines, it wasn't really there anymore. We hadn't that emphasis on the chain of survival anymore, but now we reintroduced it. It looks very similar to the older versions of the chain of survival, but it's a bit adapted. We've joined links and paid special attention, for example, for rehabilitation, but also for prevention of cardiac arrest. And the chain of survival should now be used in a multitude of settings, in a multitude of situations, from stakeholder discussions to, well, educational situations, etc. Then, basically, we also have these systems guidelines to address stakeholders, to get recognition for our problems, to, well, make all the other recommendations possible, to address them and say, well, there's systems that we need, and these systems are a comprehensive, well, net of things, or the chain mail that we've seen in the lecture before. For example, we specifically say now that children should be taught CPR in school. This is a direct recommendation now. Also, we address EMS specifically now, EMS and dispatch centers. For example, we say, well, all ambulances going to cardiac arrests, of course, must have a defibrillator with them. This is common sense, but now this is a direct recommendation that you can also talk to stakeholders about. Concerning dispatch centers, there's some emphasis on the recognition of cardiac arrest. When people call whatever emergency number they have in their countries, well, the dispatcher should also have education and training on recognition of cardiac arrest. Then they can aid the layperson not only in guiding CPR, but also guiding them through the recognition of cardiac arrest. So they need training. There should be emphasis on that. Also, then again, further the chain of survival, further along the chain of survival. When the ALS units arrive, well, we now recommend that these not only consist of any paramedics, but if they, well, want to deliver optimal ALS, as we've heard in the previous speakers, we want critical care teams to be on scene. We want experts to be on scene, professionals that can, well, apply all the recommendations that we, recommend in the ALS chapter, right? And then one last highlight, I would say, is what Enrico has also already touched, the low resource settings. The low resource settings is not a synonym for low income countries. This is very, very important. Low resource settings can happen everywhere. So imagine a very rich country with all the systems in place that you can imagine, highly professional EMS, etc., eCPR, everything. But then you go to the countryside, and it's a bit of a remote area, right? For example, Austria, where I come from, if you suffer of cardiac arrest in Vienna, you have a high chance of getting very fast, very professional ALS and everything after. But if you go to the Alps, go into the mountains, this is not the case anymore. This is a low resource setting. And this is why we've introduced, well, some thoughts on low resource settings to all the chapters, not only the systems chapter. We explain it a bit more in the systems chapter, but as you can read in the guidelines now, all the chapters have aspects of low resource settings. And this is not adapted recommendations now, because we are still learning about it and still starting about, well, learning what low resource settings need in terms of recommendation, how to adapt recommendations, how to tailor them to situations. So this will be a challenge for the upcoming years to tackle this. But I think the awareness is now there.
Thank you very much. Yeah, it's great that you mentioned the low resource settings not being necessarily low income countries. I work in a tiny, tiny island in northern Canada where it's one physician in the ER, and we just got a CT scanner, so definitely changes how you do things for sure. Thank you for highlighting that. So now it is time to review the updates to the ethics guideline, and for that we have Johannes with us. So Johannes, what are the latest updates you want to share with us?
Thank you, Sarah. So I think it is important, or it is appropriate, to start similar to what Sebastian has said. This is a chapter or guideline that interlinks with many other chapters and other guidelines. And we have 9 main topics that we structured our guideline along, and that was guided by an amazing team and supported heavily by an ethicist as well as a patient partner, which I think will provide the appropriate perspective on many of our questions. When we think about the ethics guideline, it has relevance, of course, for healthcare providers, for healthcare professionals, for researchers, for patients, survivors, and for the public in general. And with what we write, we tried to make this accessible and apparent and practical. So the goal overall is, and I'll highlight 4 parts of this, but to provide guidance for ethics and resuscitation before, during, and after CPR. So the first one I would like to highlight is, it is not new, but we really emphasized it again and made some changes to that, and that is advanced care planning. So advanced care planning is something that we recommend for all patients at risk who want to take this discussion. It is our role as healthcare professionals to enable this, to enable that patients can share their preferences and that we can engage in shared decision making. Generally, it's also important then, what we say is that these decisions that are being made, they need to be accessible. So when they're needed, we can see them again and then know what the patient's wish was. Again, that situation might change, so it needs to be reassessed regularly, especially when the patient's situation changes. Another important topic that is definitely worth highlighting is termination of resuscitation. This is a challenging decision that needs to be made or has to be made at times. But what we emphasize in the guideline is that this is always a holistic approach. There's not a single parameter this should be based on. This should be something that takes into consideration multiple factors and also takes into consideration patient preference and values. It is a team-based decision when it's done, and after it's done, it should be followed by a debriefing for this team. We also emphasize that the TOR rule is something that is only to be used for adults with out-of-hospital cardiac arrest after local validation. And that is a change from previous guideline. Taking a little bit of a shift from the clinical perspective to the research, because we also have that in there, and we make several recommendations and statements about research, how research should be conducted, and we make a specific emphasis on patient and public involvement. And I think, thinking back to the lecture from Katie, I think here we heard some important examples why that is important.
Definitely.
And our guideline really tries to stress that this is a research with patients as partners. They can be involved across the research journey, meaning in the conceptualization, in the design, in the implementation, and then also in the dissemination. And I think it is something where we recognize that maybe there's a gap to close, but I think we put this on this slide and put the emphasis on so that we can get better at this as a community. Then what is new is that we make specific recommendation for education, so education of ethics. And the simple reason for that is, I think, and we agreed with that in our group, is a guideline is only helpful if people use it. But to use it, they need to learn it and understand it and then put it into practice. So we made the argument and provided some examples on how can you learn or include ethical reasoning as a core competency in resuscitation training. And I think that is maybe even the most important message, because it's also a little bit of a call to action, because that puts it also on us to learn what is in this, to consider these ethical aspects in resuscitation, and then provide the appropriate care and good decision making during, before, and after resuscitation.
I'm quite interested in this focus on education on resuscitation ethics, and so how are you hoping to communicate this call to action to medical faculties, training programs? Perhaps some of them are in here in this room today. How are you hoping to share that call to action with them?
I mean, of course, this is interlinked with the general dissemination of the guidelines. We provide specific examples, how this can then be put into action, how this can be included, and some might already do that, and it kind of would reinforce it, but we think it can be included in courses, it can be included as online modules and learning, but I would also say that it is always something that can start with the individual, taking this to your EMS station, your next debriefing, that these considerations for ethics and resuscitation are being discussed with trainees and your colleagues so that they are being put into practice.
Thank you very much, Johannes, for sharing that with us. We're going to stick to the education theme with Sabine here, who's going to give us the update on the education guideline. So Sabine, over to you.
Thank you very much. First, let me start by thanking the working group of this guideline. It was an amazing and intense experience to work with all of you. As you can see in the back of the slides, there's a couple of key messages that we came up. I cannot focus on all of them today, so I'll pick a couple of them. The first and the biggest part in the guideline talks about targeting or tailoring the education towards either the people that have to be trained, or the patient groups, or the setting, be it like a low-income setting or a remote area, for example. I'm thinking here about, for example, the differences between healthcare professionals and lay providers as an example, as well as, for example, kids. There is some emphasis in the guideline now that kids need some targeted education as well, and we put another emphasis for kids as well in that education guideline, that education should start early, around 4 to 6 years of age, and then ideally be continued yearly throughout their education, throughout their life, actually. That would be great. One new thing in this guideline is talking about cognitive aid use, and the recommendations that we have seen and the literature that we have examined on that topic in accordance with the ILCO guidelines were like that cognitive aids are helpful if they're used by healthcare professionals in resuscitations, but they are not so helpful if they're used by lay providers, because they can have actually a delay in the start of resuscitation at that time. Parts of the guideline are talking about technology-enhanced learning and distance learning. A lot of these things are in the beginning. They're, if you will, children at this point. They need to grow up a little bit. So we're hoping over the next couple of years that we're getting some more evidence there. And in the next guideline, there might be some more important updates on that front. The last thing I want to mention here is that the guideline we decided to include for a recommendation for instructors of resuscitation courses to actually include team debriefings after a cardiac arrest scenario has been practiced. This to encourage clinical debriefings in real situations, ideally.
And I want to follow up on that. What motivated this last update to include team debriefings in the life support courses training themselves?
Yes, there is two parts on this. So basically, the evidence that we have on clinical debriefings in real-life situations is weak, but it's actually beneficial for the patient outcomes. The other part is that debriefing can be helpful in diffusing situations for participants or for participants of real-life cardiac arrest. So with that in mind, a debriefing should always be to find out what has happened and why it has happened, and ideally to find a way of how we can change it or make it better in the future. So with all of this together, we thought it would be reasonable to suggest that we should incorporate this in the training courses with the hope that it will be more incorporated in clinical day life. Obviously, more research is needed in the end to validate if that is the right approach.
Thank you very much, Sabine, for your answer. And please all join me in thanking our 4 speakers for sharing their expertise with us. Thank you. Thank you. Thank you. Thank you. All right, last but certainly not least, let's please warmly welcome to the stage Jana Diakov, Marija Hoogeveen, Tessa Djarv, and Tino Greif. They will share the updates on the PLS, NLS, and first aid guidelines, and Tino will review the executive summary. Thanks so much for being with us, guys. All right, let's start with you, Jana. So what are the key highlights or headlines in the updated PLS guideline?
So thank you for having me here on stage. And just to say as a welcome, I am here on behalf of the whole writing group. I have to thank them all. They did a wonderful job. And of course, I also have to thank those behind us, because it's not only the team that is working, but also people who are supporting us through this journey, our partners, families, colleagues, and so on. So what's new in pediatrics? Well, first of all, we've tried to cover almost everything that our pre-speakers were talking about for adults. Then we are covering it for the tinier people. And it was very, very challenging to put it all together, but I hope you can find there most of the recommendations for all the environments. So what we are talking about most in pediatrics, and that's not new, but it's oldie but goodie, that's a prevention of cardiac arrest, that the best cardiac arrest is the one that doesn't happen. And that's something we want to really emphasize throughout our guidelines. Then we also emphasize the teamwork as well. What is more, and I'm very happy that there was Katie talking about some humanist picture, because we've tried to cover that. I think the whole working group was really a group of humanists. We've tried to also take the view of the families, and the family-centered care approach is going really around through our guidelines. So that's what we try to do in a new, innovative ways. And as you could hear from my colleagues before, we also try to reach to other groups, to the BLS group, to make the universal algorithm, but still keep the pediatric side, like what's important for the children. And hopefully we can be happy about that algorithm. Also, what's completely new, and that's a big part of our guidelines now, is the bigger part on the post-resuscitation care, post-discharge care, and prognostication. And again, I feel that this is very important for our families, not only for the survivors, but also for all who are co-surviving with them, to have a plan for post-discharge care and a view for a high-quality life afterwards, because for children, it's many years ahead. So that's even more important, I would say, than for adult patients.
I want to follow up on that. So can you tell us more about what motivated this focus on post-resuscitation and post-discharge care so central to make it part of the algorithm?
Well, first we felt that's something that was not there before, and that we really need some guidance on that. And second, there also was a very good scientific reviews from ILCOR about prognostication. So we could also had a grip on good science on that. And there's a huge humanist approach, as I must again cite Katie, to really think more about not only the patient who survived, but the whole community and the whole family together.
Thank you very much, Jana. Let's now turn our attention to the teeny tiniest and smallest of humans with the update on NLS. And for that, we have Maraya. So what are the main highlights here?
Well, thank you, and of course, also my writing group. Well, our guideline is maybe a little bit different because we're not only dealing with the full-blown resuscitation part, but also with supportive transition of babies at birth. And altogether, that makes approximately 10–11% of babies do need some form of help at birth, which is quite a lot. I think one of the things that we've added this year for the first time together after discussion with our pediatric colleagues is some recommendation on when to use the Do More life support algorithm and when to use the pediatric life support algorithms. Because it's one of the most frequently asked questions that we receive in courses, etc. And it's very clear, at birth, you need to do the NLS algorithm. And on the other side, it's also very clear, a baby of 4 weeks old who comes into the hospital, you need to do the pediatric to use the pediatric life support algorithms. But as always, there's some gray area in between, and we've tried to put some recommendations into our guideline to help people. And I think the most important message is that we cannot provide hard evidence on when to use which algorithm in that population. So it depends on your patient case mix, on your logistics, on human factors, on how your team members are trained, but you need to have a local policy.
For sure.
So that's the most important thing. So everyone go home, check whether you have a local policy, and if not, please create it. So that's one thing that's new. I think we put emphasis on altered approach not only for preterm infants below 32 weeks, but also on the altered approach, which might be suitable for this audience, of out-of-hospital births. And we might consider them lower resource settings, even when they're planned. Equipment, team, the setting is still different than all the availabilities you would have in the hospital. So the main things that we put emphasis on, because the main problems in out-of-hospital births are hypoxia and hypothermia. So we try to warn people, please pay attention, keep the baby warm, prevent hypoxia. And we know the equipment is different, so you cannot titrate oxygen probably when in an out-of-hospital setting, and you might not have a PEEP and an inspirator pressure that you can, very detailed, use very detailed, but there's much more things that you can do, and these are the two main problems that you might try to prevent. And of course, there's also the importance that in an out-of-hospital setting, whether it's planned or unexpected, you always have some transfer to a hospital, usually. So you need to take that into account as well and have a communication and a referral plan when something happens like that.
If you had to pick just one key message for everyone to keep in mind about how to care for these little neonates, what would it be?
Don't be afraid. Simple things can save lives. Just start with drying, keeping them warm, stimulating them. Most of the babies just need these measures. Some of them need your respiratory support, and only 1.0% needs just compression. So simple things can save lives. And if you want to practice, there will be 3 hands-on NLS workshops during this conference, 1 each day, so you can actually come and play with us and practice your NLS skills.
We certainly encourage you all to do that. Thank you very much, really appreciate that. And now let's go over to the updated first aid guidelines with Tessa. So Tessa, what are the key messages you want to share about this update today?
Well, thank you. So the first aid chapter is not an update, it's a totally new chapter. We actually, I think it's 90% new, actually. And the story of that is that we started off with first aid is something all of us do. and it's sort of a helping social behavior, but for most things we don't need a guideline. So why would ERC have a guideline? And then realize, like, it's resuscitation, and all resuscitation starts with first aid, and if we do first aid correct, we might not need resuscitation. So that was where we started off, and then we focused on life-threatening conditions. So we added 10 new topics and took out 8 from the old guideline. We also realized that first aid text is not really gonna be helpful, so we have a lot of infographics, which is really nice. We also have a one-page summary, which you can print and put on your toilet doors or wherever you're gonna have them, like that, to remember how to do it, because that's what it's gonna be. So that's a really big thing for us. We also added new topics, and also the structure that we actually think that we should tailor first aid courses, because we are different, and I mean, we need to reach equity and equality within first aid, and having outcomes for everybody needing first aid in life-threatening conditions. So we have strengthened that. One of the key messages is to tailor first aid courses, not to have the same recipe for everybody. But we also added, like, the ABCD approach. We believe that even first aid providers need a structured approach to a life-threatening condition. We have added how to act in a drug overdose, if you have suicidal thoughts, and many other things as well.
I want to ask you more about this, because when I was reading the guideline, I was quite struck by this addition of mental health crises, such as having suicidal thoughts. I found it really interesting that it's included in the first aid guideline. So can you tell us what you were hoping to address by having this in the guideline?
Yeah, I think you have the same reaction as many in the writing groups. I don't want to mention any names, but there were many people saying, oh, you can't add that, that's going to be dangerous, because this is a myth. If someone has suicidal thoughts, we should talk to them, not be afraid of talking to them. So that's why we have that. And we have a session tomorrow morning about how to do that. So everybody's welcome, of course. But I think that was the point of actually taking out myths and actually saving lives.
Thank you very much. We really appreciate it, and we look forward to tomorrow's session as well. And last but certainly not least, let's now hear it from Master Yoda Tino, who will go through the top lines of the executive summary for us.
So the executive summary is a kind of strange, it's not even a guideline, it's a strange chapter, because in the first part we summarize a little bit how the guidelines were produced, what is behind the thought, what is the evidence. And writing this down was rather easy for me, because I have to thank Gavin Perkins for a very nice chapter for the last guidelines, which I used as the structure, and not that much changed in the process. So we described a little bit the changes from the ILCO reviews and how we use this. And then the chapter is, thanks to all the writing groups, essentially the recommendation, a summary of all the recommendations, and some algorithms we thought were maybe a little bit more important or more illustrative. I personally find this chapter rather boring. No, it's a list of bullet points, and Jerry and I, we were discussing a little bit. Certainly for the next time we have maybe more time, this has to be changed. So reading this endless list of bullet points is hard work. So we need to present this overall for users in a different way. Otherwise you get lost. So, but in the end, it's a summary of all the recommendations, and you find the major algorithms in there. I would strongly recommend to go to the original guidelines, because in each guidelines they have at the beginning the concise guidelines for the clinician, which are these bullet points. But then the second part is always the evidence-informed guidelines, which is the entire text of why we made these recommendations. So this is really the interesting part. Why? What is the reason? What is the justification for a guidelines or not? And this gives you then the entire picture why we are doing this, what we are doing for the different areas. That's all what I have to say for the executive summary.
Well, thank you very much, and we'll keep our eyes peeled for the 2030 guideline update to see what comes of the executive summary and whether it's so bullet point full or not. So thank you so much to all of you for sharing your time and your expertise with us. Please join me in thanking them. We really hope you enjoyed getting these highlights of the guideline updates, and we really look forward to having you all join us on the following sessions where we're going to go into more details for each guideline. It's been a true pleasure and a privilege to moderate this session, and with that, I'd like to hand it back to Tino for the conclusion of the opening ceremony. Thank you all very much.
Please, please, stay a moment. The most important stuff comes now. People heading out, unbelievable. So, you have these guidelines. These are the guidelines, the executive summary on the web page, already available. You can download everything. What else? We tried to implement this. So we produced a lot of pocket cards for the clinicians. We produced leaflets for the communities, for everybody, to inform them what does it mean, epidemiology in resuscitation. You will, that's not so good. You will find some stickers to place wherever you want, all what's socially acceptable, for implementation and put the importance of these new guidelines. We produced, as I said before, this layperson version. You can download this already from the web page for the community, for yourself, hospitals, organizations, national resuscitation councils, or companies even can have a special version for print this with their logo on the last page. And finally, yeah, I skipped one. You will find on the ERC booth, and I really highly recommend to pass by, a lot of merchandises with the new chain of survival, which we have here, and the special chain of survival. And this is a big thanks to all these people who worked in the office. And that's for you. The last one for Federico now.
So, thank you, Tino. Amazing. So, please take a photo of you in the chain of survival, put on social media, and please, there is always an app for everything. So, from now, you can download the app of the guidelines. You can find everything about the guidelines in this app. Please download the app. You can find document, material, infographics, everything. But please take a photo of you in the chain of survival during the coffee break. That is now. And it's always, you used to say, we need to finish 15 minutes to 3, and we save 6 minutes.
We gave you back 6 minutes of your life.
Yeah. Coffee break. Thank you so much.